Bismillah ar-Rahman ar-Rahim. Distinguished chairpersons, dear colleagues, Assalamu alaikum. It's a great privilege and honor for me to be at Cardiology Update after a long pause because most of the time in June I am out of the country. So I'm grateful to Brigadier Nadir and Brigadier Samoor and General Farhan for inviting me and being with you on this occasion. Now, I have got a very humble and simple presentation of a condition which is less often discussed and relatively newly acknowledged or diagnosed. Broken heart syndrome or Takotsubo Cardiomyopathy. Now, we all hear every now and then that किसी का दिल टूट गया, किसी को सदमा पहुंच गया, or this is in our literature. Our poets have 2 centuries ago mentioned that Dili to hai na sango khisht, dard se bar na aaye kyun. So ये तो सबको पता है कि दिल के ऊपर बड़ा असर होता है, लेकिन we all thought this is just an emotional statement or perhaps just a myth statement which has got no pathological significance. But now we know that it has a significant pathological connection. Now, these are some of the triggers that lead to this cardiomyopathy, in which there is acute dysfunction of the left ventricle resulting in failure, and there is a ballooning of the apical segment, which we'll discuss later. These are some of the known triggers which lead to broken heart syndrome or Takosovo cardiomyopathy. Bereavement is the most important, and we all know from our practice that some of your patient, when he dies, his spouse also passes away soon after because of bereavement and the effect of bereavement. Domestic abuse, financial losses, facing disaster like floods that we are at the moment confronted with, sudden and severe illnesses, and sometimes recent major complicated surgery may lead to Takosovo cardiomyopathy. This is the kind of situation we are faced with, and no wonder a lot of people have lost their livelihood, their houses, their dear ones, and most of them they'll develop some sort of cardiomyopathy in the days to come. Now, this cardiomyopathy or LV dysfunction was first described by a Japanese cardiologist. Names are so difficult because Shahbaz has lived there, so he will know. I could not memorize his name, but it was 1990 that we came to know that there is a definite entity called cardiomyopathy due to Takosovo heart muscle dysfunction. The hallmark of the disease is transient severe LV dysfunction involving the anteroapical segment of the left ventricle, which results in its ballooning, and this ballooning is, you see, is similar to a utensil or a cup which is used to catch jellyfishes, and that's how it is known as Takosovo cardiomyopathy. It usually follows a severe, intense, acute stress, and it's also sometimes referred to as stress cardiomyopathy. What are the risk factors which predispose to broken heart syndrome? It's much more common in women. In some series, they say 95% cases belong to female gender. Most of the patients are past their middle age. Previous or current mental health problem also is a predisposing factor, and use of certain stimulants like cocaine and methamphetamines are also liable to predispose. The diagnostic criteria is laid by Mayo Clinic, but I think you have to have certain markers or certain points to suspect this syndrome. Suspicion of acute myocardial infarction based on precordial chest pain and ST elevation observed during acute phase. The presentation is very similar to acute myocardial infarction. That's why it is sometimes so difficult to differentiate between two. So one has to exclude the coronary artery disease then to diagnose cardiomyopathy. There's transient hypo or akinesia of the middle and apical LV regions and functional hypokinesia of the basal region observed on left ventriculogram, echocardiogram, and MRI. Normal core angiography is very important to diagnose if the criteria is that the luminal narrowing should be less than 50%. Absence of recent significant heart injury, intracranial hemorrhage, myocarditis, or suspicion of pheochromocytoma should exclude the diagnosis. The pathophysiology is not exactly known. However, coronary microvascular dysfunction, abnormal catecholamine release, that's most important point, and which results into sort of myocardial stunning. And stunning means जैसे वो आदमी शुशदर रह जाता है, myocardium becomes totally stunned and becomes non-functional. Decrease in estrogen levels, and that's why it's found that 90% of the victims are post-menopausal. So there is some protective effect by estrogen. Coronary vasospasm is another contributing factor. Myocardial microinfarctions are also implicated, and abnormalities of cardiac fatty acid metabolism. So these are some of the explanations in the mechanism. The most common presentation is chest pain, and it's very difficult to differentiate between acute coronary syndrome and this cardiomyopathy. ECG abnormalities always also mimic myocardial infarction, and you may have associated palpitation, sickness, and dizziness. So initial presentation or impression is ACS, and usually treated as ACS. Once ACS has been excluded and we have got some other diagnostic workup done, then you diagnose it as Takosovo cardiomyopathy. This is the basic workup: ECG, cardiac markers, echo, coronary angiography. MRI is supposed to be the most sensitive tool, but where it is not available, echocardiogram is quite appropriate and informative. Wall motion abnormalities and delayed gadolinium enhancement is another way of diagnosing it. These are the kind of changes that you see, which are very similar to acute coronary syndrome, MI. So this is what happens, that the left ventricle becomes sort of a balloon, and this is the utensil. इसके साथ इसको compare करके इसका नाम दिया गया है, because there is a neck and then there is a sort of flask-shaped dilatation. This is what happens to our left ventricle in this syndrome. It becomes dilated, ballooned, and therefore the function becomes impaired. It's supposed to be a transient phenomena which should return within a couple of weeks, but sometimes it can persist and it can lead to complications. And this is very easily picked up on echocardiogram. This is how it's shown on the echocardiogram. You can see the ballooning of the apical segment of the left ventricle. The differential diagnosis of the disease is from coronary artery spasm, esophageal spasm, myocarditis, cocaine-induced cardiomyopathy, acute pericarditis, aortic dissection, spontaneous esophageal rupture, and pneumothorax. Treatment of the acute phase is symptomatic, depending upon presentation, pain relief. Hemodynamic unstable, then you have to resort to some sort of support like IABP and anatropes. Cardiac stimulants, controversial, only used in 20% cases. This is under trial cardiac anatrope, which is still used in some places. Anticoagulants are used until the recovery is complete to avoid any thrombotic episode. Pharmacotherapy of Bhurban syndrome won't take more time. Okay. For severe LV outflow tract obstruction, you can use beta blocker and adrenoreceptor agonist, phenylephrine, to reduce this is gradient. You can use calcium channel blocker for suspected vasospasm. Again, calcium channel blockers, diltiazem, verapamil can be used. People who are hemodynamically stable, you can use diuretics, ACE, beta blockers, just like anti-failure treatment for any other condition. No consensus on duration of treatment, mostly till the recovery of systolic function. Prognosis is supposed to be very good. It's said that 95% of the cases should have complete recovery. Failure to recover within 12 weeks warrants an alternate diagnosis. So that's the statement. A small minority can go into cardiac arrest. There's a possibility of recurrence in small percentage after a couple of years. Poor markers or extent of ECG changes, severity of LV dysfunction, level of NB rise, and female gender and advancing age. Conclusion: total Takotsubo cardiomyopathy is a definite clinical entity, not so uncommon. Since the recognition of this syndrome, the number of cases are on the rise. Almost 95% patients should recover completely. Chest pain remains the commonest presentation and should be added to the differential diagnosis of acute myocardial infarction or ACS. Massive sudden release of catecholamine is, I think, the most important factor in causing the syndrome. High prevalence of postmenopausal women suggests important protective role of estrogen. So that's very important to know that this only occurs in postmenopausal. बस ये खत्म हो रहा है सर, आप फिक्र नहीं करें. आखिर में जो सबसे इम्पॉर्टेंट चीज़ हमें सिखाई गई है और जो हमारे लिए इलाज क्रॉनिक वो ट्रीटमेंट है कि वो जब हम पे मुसीबत आए तो हमें सब्र करना चाहिए और उससे मुकाबला करने के लिए अल्लाह ताला की नुसरत हासिल करनी चाहिए. So with this, thank you very much for your patient listening, and we should all pray for our flood victims that they should be rehabilitated and they should go back to their houses. They are under tremendous mental stress और हम सब का फ़र्ज़ है जैसे जनरल सोहेल ने कल कहा है जो भी हम दे सकते हैं कार्डियक सोसाइटी को दें and it should be passed on to these victims. Thank you very much.